Ladies and gentlemen, now we are moving to one of the most prestigious events in the Congress. To honor his lifetime visionary contribution to the field of vascular surgery, the Sri Lankan Society for Vascular Surgery is privileged to award the most coveted Professor A.H. Sheriffdeen Oration. To introduce this year's orator, may I kindly invite Professor Mandika Vijayaratne, past president of SLSVS, to the stage.
Thank you. It is an honor and a joy to introduce today's orator, Ranjuka, Ubayasiri. The Sri Lankan audience knows Ranjuka extremely well, and he actually needs no introduction. If I tell you, but I will introduce Ranjuka because there are lots of you who don't know him. If I say Ranjuka is a vascular surgeon, yeah, definitely he's a vascular surgeon. He's a great surgeon. Additionally, he models. He's a master at Canadian dancing. He's a great athlete. It still misses something about Ranjuka. I've been wondering how, well, I've known him throughout his surgical training, starting in his during his registrar period and his entire postgraduate training in vascular. And I've been wondering how to get this aspect about the man today. So, yes, let's go back to 1912, 15th of April. The Titanic was on its maiden voyage in the North Atlantic. It was struck, I think we all know it, struck by an iceberg and sank over a short period, 2 hours, 40 minutes, with 2,208 passengers, including crew. And the ship fired rockets into the sky, the flares, and radioed for help. And what happened? There was a ship known as Samson, which was approximately 7 nautical miles away from the Titanic. And the captain decided, well, they were up to some naughty stuff. They were illegally hunting seals. And they thought, no, I think we better not get involved in this. And they moved away. that was 7. 14 nautical miles away was another ship, Californian. And the captain got all the messages, but he said, it was night and there was ice. And he said, I think the conditions are not right to move towards Titanic. We will reassess the situation in the morning, next morning. And that was it. 58 miles away was Carpathia. The ship, the captain was completely different. He decided to immediately turn. It was going south, turned north, came through the ice, and it saved 708 of the passengers who eventually survived. It was 1 out of 3 who were saved. Now, yes, there are people who will not be too bothered about other people in trouble. They'll move away and look after their prosperity. And there will be others, quite a majority of us, who will say the conditions are not right. We can do help, but we will do it when we are ready, when things are better. But here is Ranjuka, the Carpathian. You call him, anybody calls him in the hospital, not just vascular, any general surgeon, any junior surgeon who is in trouble. And Ranjuka will come there with a smile, calm, and sort out any mess. He is such a great craftsman as a surgeon. He's well known for that. He does it with joy. So I think that is the essence of Dr. Ranjuka Ubayasiri, who, in fact, he attended my old school, Royal College, in 1980, and he was in basketball. He got colors in basketball and athletics. He was the athletics captain, a prefect, and he did extremely well in his studies. Naturally, he got into Colombo Medical School in 1994, where he again continued with his sports, got university colors in athletics and basketball, and won an award, DPP Samarasekara Medal, and qualified with honors in 2001, and he then moved on to do his internship in the university unit, in which I also worked, and he was one of those star interns, and then he continued as a registrar. And in 2000, and he was a surgeon. He was a born surgeon. Can't imagine this guy doing anything else. And he was in the Master of Surgery program when he went through his exams, plain sailing. And in 2007, he qualified MS Surgery, 2007. And we were lucky that Ranjuka decided to pick vascular surgery. And here he was our senior registrar in the next 2 years. And during this time, he also did black belt karate, modeling, Canadian dancing. He is quite a all-rounder, quite a character, and a fantastic surgeon, craftsman, for those who know Ranjuka. Then he moved across to for his overseas training to the Royal Free Hospital for a year in the vascular department, and then went over to Auckland, New Zealand, for a year in transplant surgery. And he was back in Sri Lanka in 2011, and soon after that he was sent over to Karapitiya, the capital of the south, which never had any vascular surgeons until then. And Ranjuka, I remember, he was very depressed that he was going to leave Colombo, and we had this chat, told him that, we have an expressway, it's not too far from Colombo, and Ranjuka took the challenge. He said, let me go and see what happens. And rest is history. Ranjuka transformed vascular transplant services in the entire South. And he's done it single-handed. He's the only surgeon. And he does a lot of training registrars, senior registrars as well. And his wound care, he's so well known for his wound care, he's called Vanaraja. That is ulcer king of the South. And it goes on. He's going to tell you about all the stuff he has done as a vascular surgeon, especially bringing up Karapitiya to what it is today. He was also awarded, there was a national presidential award for Ranjuka in 2019 in recognition of his fantastic services. So Ranjuka is married to lovely Nilu and has 3 children. The eldest started her medical training, and I wish Ranjuka many more years. He is pretty young. He's got a long time to go, and wish him great journey. You've got a lot more time to bat, and wish you all the very best, and eagerly wanting to listen to your presentation today, Ranjuka. Over to you.
Thank you, sir, for that very generous introduction. Good evening. Our chief guest tonight, Professor Alan Davis, our guest of honor, Professor Jonathan Boyle, and Dr. Alexandra Jaruka, Professor H. Sheriffdeen, distinguished guests, dear colleagues, ladies and gentlemen. Professor H. Sheriffdeen Oration, Sri Lanka Society of Vascular Surgery, 2026. Professor Sheriffdeen is an emeritus professor of surgery in the University of Colombo. He is the founder of vascular surgery in Sri Lanka. He is also the co-founder of Sri Lanka's organ transplant program in this country. He's an educator, he's a trainer, he's an iconic figure not only for vascular surgeons but for all surgeons in the country. Abdul Halim Sheriffdeen was born during the last stage of British colonial rule. He was the 8th family member of 11. He initially schooled at St. Andrews, Nawalapitia, then later on moved to St. Anthony's, Katugastata. Not only a bright student, but as well as a cricketer, and he had college colours, a spin bowler. He started his medical education in 1959, completed his MBBS and internship in 1964, and joined the Department of Surgery, Colombo, in 1968. His initial ambition has been to become an orthopedic surgeon, but for our luck, he decided to do vascular surgery. He went to UK in 1969 and was trained under Professor Harold Ellis in general surgery and Dr. E. Scott in vascular surgery. After gaining the experience, he came back to Sri Lanka and established vascular surgery in this country. He performed the first aortofemoral bypass, femoropopliteal bypass, so the arterial suturing techniques, the anastomosis that we have taken for granted today has been introduced by him, this great surgeon. He has published extensively in both national and international journals. He is the Millennium President of the College of Surgeons of Sri Lanka, and for his exceptional work, he has been given the National Awards of Deshabandhu in 1987 and Vishwa Prasadini in 1996. He was a chair professor of surgery in 1989 till 2003. And not just an exceptional surgeon, he was a humanitarian. He found the Friend in Need Society. He was the co-founder of the Jaipur Food Program in 1983, which gives prosthetic limbs to the amputees island-wide. So I still remember him as a medical student as well as one of his RAS registrars. So it's indeed my great honor and pleasure to do this oration which is in his name. Thank you, sir. So my oration today is Vision to Excellence, a 14-year journey establishing a premier vascular and transplant center in southern Sri Lanka. This is the third dedicated vascular unit established in the country other than Colombo and Kennedy. It serves the entire south as well as the Uva provinces. And it's the only vascular training center other than Colombo training future vascular surgeons. We had a very humble beginning. As the 6th board-certified surgeon, I was appointed to the south in 2012. But although I was appointed, when I went there, as Prof said, there was no ward, no theaters, no instruments to do vascular surgery, and there was no space to do a clinic, and there were no medical officers or a unit to begin with. So I was quite depressed and thought my dreams of becoming some sort of a good surgeon is all gone. However, slowly things began to fall in place. Dr. Sudhir Herath gave me some accommodation in his ward. Then I used to see patients on the corridors of the outpatient department with wounds and ulcers, very cumbersome. Then director Dr. Shelton gave some space, a separate clinic for our patients in the same vicinity, which gradually expanded over time. Then there were no theater equipment, so no instruments to do it. So we found funds, personal funds, borrowed, and made a set of instruments to start vascular surgery. There was no theater, so I had to wait until the general surgeons finished or used casualty lists or weekends or public holidays or whenever they were abroad. I used to do vascular surgery. But then I realized there was a theater which was closed for a long time, theater A and B. Then with the help of the director and the ministry, we got the theater lamps, theater tables, got the renovation done fast, and I quickly moved in. So then I was given 5 theater lists, which then put some solid long-hour surgeries and developed vascular work gradually. So in 2014, I was fortunate enough to produce an audit to Professor Sheriffdeen and Professor Ratnatunga to get postgraduate trainees. And Madhivadan came as our first senior registrar, and from there on, every year, 2 senior registrars came to our unit. So our patient numbers grew, and I had to move from the initial ward to our professorial unit in Karapitiya. I remember Professor Kumara, Professor Ranjana, Professor Kumarasinghe, Professor Rajitha, all of them were very accommodating and helping me to do work there. So they gave me space. I taught them medical students. So gradually, the work progressed, and 2015, we realized we needed a separate area for do the vascular work, transplant work, as well as nephrology work. So we had the foundation stone laid. At that time, Health Minister Dr. Maithripala Sirisena and Dr. Shelton Pereira, myself and Dr. Sanjay, and designed and found space and started, got the funding for a new building. However, the country was in a bad situation for a while, and it took 7 long years to finish this. But the work continued. In 2022, we moved into the new ward, and after 3 more years of hard labor, the current director, Dr. Ranjuka, really helped to get the theatre open. We moved into the new theatre. So this is a state-of-the-art theatre, which is designed for hybrid work, endovascular as well as open. However, we still don't have a CM. I'm sure our director is working on it hard. So after long years of labor, finally we have 4 days of full theatre. We do 5 daily clinics in the morning. Each clinic is attended by about 80 patients with wounds and ulcers. And then we have a separate clinic again in the afternoon for referrals. And probably this is the only unit in the country with a surgical unit who does 6 clinics. So our wards are not burdened, but most patients are managed as outpatient. We do 24/7 trauma call and emergency call, and we do a wide range of vascular and other surgeries as well. The next few slides will cover the bread and butter of vascular surgeries, that is bypasses, that I have studied in one retrospective study, and live donor kidney transplants, as well as the last few years of work, aneurysms, carotids, vascular emergencies, vascular access, and some of the other areas that we do, and areas like liver resections, massive splenectomies, and I'll finish with some interesting cases, as well as the educational arm of our unit. So the first study is retrospective analysis of the clinical outcomes following lower extremity bypass for chronic limb-threatening ischemia and the National Hospital Goal. So this is how they present, with necrotic feet, dry gangrene, sometimes wet gangrene, septic patients with diabetes, and we have performed over the past few years 752 bypasses. However, after the introduction of the angioplasties in the hospital, the numbers have slowly come down, because we used to do even high-risk patients with bypass surgery. The commonest is the infrainguinal. We have performed 395 femoropopliteals and 258 pop distals and 101 above inguinal aortic procedures. When you look at the demographics, commonly male 65%, female 34%, and this beautiful old lady here is a 92-year-old, our oldest that we have performed a bypass. You look at the socio-demographics, the commonest factor is diabetes, and still smoking is an important factor. In the suprainguinal bypass of 101, most aortofemorals, which have really come down after introduction of angioplasties, as well as for the unfit patients, we performed extra-anatypical bypasses like fem-fem crossovers and accidofems. The infrainguinal bypasses, the commonest is a popliteal bypass, as well as popliteal bypass, about 258. In a retrospective analysis of this group, we chose the surgeries done from 2019 to 2026, 495 bypasses, and only 218 could be followed up because this was a retrospective study, and the records were lost or their numbers didn't work, and our research assistant could not get through to them. In this study, the mean follow-up time was 21.3 months. The overall survival in this group with a 30-day mortality was 7.6%. And 1 year survival was 72%. And amputation-free survival in the first year was 58%. We compared the different types of bypasses, whether they made any difference in the outcome. There seemed to be no difference in the outcome. In summary, our 30-day mortality was 7.6%, with 1 year survival of 72% and 1 year amputation-free survival was 58%, which is in keeping with the international figures, but the mortality is slightly high because initially we only had bypasses in our hospital. Therefore, we have taken high-risk patients also and put them under a bypass. Now, the mortalities have come down in the last couple of years. We do some extreme salvages. Even a toe we will try to salvage with revascularization and wound care. And these are some of the salvages that we have done over the years. Then let's move into kidney transplantation. And I cannot start about transplantation in the South without speaking about these three giants: Professor Sheriffdeen, who was the recipient surgeon at that time, Professor Jerry Jayasekara, who was the donor surgeon at that time, and Professor Rizvi Sharif, who is the pioneering nephrologist who started kidney transplantation. And all three of them have been teachers and have worked under them. So it's this is how they did their first transplant in 1985. This is our team who did the first transplant in Gaul in 2012. You can see Nalak also come from Colombo to help me, and my friend Kolita was a plastic surgeon who came to help. The outcome audit of live donor renal transplantation at the National Hospital Gaul. This is analysis of the transplants that we have performed. A retrospective analysis of the live donor kidney transplants performed from 2012 November to 2026 April. There are 177, and we could follow 114, 64% of them, and mean follow-up was 56.5 months. The recipient characteristics: male to female is 2 to 1. Mean recipient age was 44 years. Etiology was commonly diabetes and hypertension. There were few cases of polycystic kidney disease, large kidneys, which we have to take out before transplanting. And for obstructive uropathies and some of the congenital cause, we do a ileal conduit when there is no bladder, and we bring it out of the anterior abdominal wall. And most of our patients had a functioning arteriovenous fistula before the transplant, 86%. When you look at the donor characteristics, mean age is 44 years, male to female is 1.4 to 1, 10% emotional donors, 26 related donors, and about 10% of extended donor criteria. Especially when a father is donating, a son or a relation is donating, we go beyond the required age or the size, BMI, and we somehow try to get the transplant done. The commonest organ that we have transplanted is the left kidney because of the obvious easy anatomy, and sometimes in 27% we have taken the right kidney. We will not shy away from any vascular variation. We will do double arteries, triple arteries, early divisions. We will all reconstruct them outside the kidneys and transplant them. Double renal veins, double ureters, all of them will be transplanted. We also started laparoscopic donor nephrectomies in the unit with the help of Dr. Erosion Senivaratna, who came to help in the initial few cases. But our common operation is open nephrectomy because of the time constraints. So we have streamlined the protocol of live donor kidney transplants with a single lead surgeon. We do simultaneous parallel theaters in these instances. And the senior registrars or my colleagues have helped opening, and the lead surgeon goes to harvest the kidney, cold perfuses it, goes to the other side and does the transplant. Average warm ischemia time is mean is 3.5 minutes, cold ischemia time of about 57 minutes, and they're extubated immediately after surgery, and they are sent to the ICU or HDU, kept for 5-6 days, and then a few more days in the ward and sent home. Look at the donor outcomes. We haven't had any mortality and few morbidities, but they do very well, and they're discharged on the second or the third day even after open nephrectomy. When you look at the overall outcome and the survival, the 30-day mortality is about 1.8%. We have had 2 deaths in this group, and both due to pneumonia. And 5-year overall survival is about 76.3. And graft survival is about 89.5%. In summary, we have a 30-day mortality rate of 1.8%, 5-year patient survival about 76%, 5 death-censored graft survival is about 89.5%. Common reasons for death after 30 days is pneumonia, myocardial infarction, neutropenia, and sepsis and graft failure. We compare the different factors, whether they have a bearing on it, like age, nephrectomy site, cold ischemia time, or extended donor criteria. They did not show any importance, or they did not alter the outcome. We have had few morbidities, like few perinephric collections. 2 patients, we had to take them back to theatre, but could not find a bleeder, but drainage and washing sorted them out. 3 lymphoseals, one needed a laparoscopic fenestration, 2 ureteric implantations, and we haven't had any vascular complications in this group. And few medical complications are rejections and infective complications. When you look at our results with the comparison with the global data, we are really in par with the best centers of the world when it comes to kidney transplantation. We also do aneurysm, abdominal aortic aneurysms. We do not have EVAs. It's entirely open surgery that we do, so we are very careful in choosing patients. We do mostly tubular grafts or bifurcated grafts, leaking aneurysms, retroperitoneal, sometimes transperitoneal, and we fix them in an open fashion. This is a patient with a suprarenal abdominal aortic aneurysm with 2 double arteries, and we did a limited thoracoabdominal incision, cross-clamped the aorta above the diaphragm, disconnected the kidney, reperfused the kidney with cold solution, reconstructed the aorta with the bifurcated graft, and reattached the renal arteries onto the graft with and preserve the kidney function. This is the patient post-op. This is a thoracoabdominal aneurysms, which is rare, but we perform them with the help of the cardiothoracic colleagues, and we do open surgery for them. We use a veno-venous bypass, 1 catheter in the IVC, and oxygenates blood from the perfusionist is given to the femoral artery, sequential clamping. We also used spinal drainage and thoracoabdominal incision, and entire aorta was fixed. This is same in the post-operative period. So we do elective and emergency aortic surgery. The technique has remained the same, but the blood loss, the time, the post-operative management, ICU stay has all improved, and we are more selective than what we were before, and so we have a reasonable outcome. We also do carotid endarterectomy, but for stroke prevention, we have performed 71 over the past couple of years. We haven't had any mortality. We have 1 stroke out of these 71. I only do, as Prof said, I only do anyway symptomatic more than 70, and they have to present within the 3 months, or they have to be recurrent symptoms for me to do a carotid endarterectomy. And we do a vein patch. We don't do synthetic patches, and we are selective in shunting with stump pressure measurements. We do a 24/7 on-call. We have performed vascular emergencies. Common injury is a lower limb injury due to motorcycle accidents and road traffic accidents, but upper limb, abdomen, neck, all areas have been repaired. These are upper limb trauma. We also have done a few reimplantations of hands. This is a patient who came recently for for abrasion of the hand that we have implanted in 2019. So she has a reasonable outcome. These are some lower limb trauma which commonly repaired with reverse saphenous graft from the opposite limb. These are some dramatic injuries which I couldn't find pictures of, and sometimes they present later with a femoral traumatic fistula. We don't have closed stents, so we do open a procedure and fixes them. Some neck trauma patients with vascular injuries. And we also provide the service of vascular access, creating arteriovenous fistula. We have done, over the years, the numbers have increased. And commonest is the brachiocephalic fistula and sometimes radiocephalic, because our population, the veins are very small. And sometimes when the cephalic is not there, we do a brachiobasilic with superficialization. Very rarely we use grafts. And we also do some venous work for varicose veins, ulcers. We do mostly lasers and foam sclerotherapy and phlebectomies. We have moved, this is how the numbers have evolved from surgery to laser and foam sclerotherapy. These are carotid body tumors. We have collected 10 over the last few years, and different stages, sometimes encasing the entire carotid. We have repaired with less morbidity and mortality. And we do arteriovenous malformations of different sites, open surgery. This is a dorsum of the arm. This is how it looks after surgery, preserving the function. We also do cervical rib resections for not only for vascular causes but also for thoracic outlet syndrome causing neurological symptoms when the physiotherapy fails. So we remove cervical ribs, cervical bands and scalene muscles. This is a patient who had a post-stenotic dilatation with a thrombus causing upper limb ischemia. We have resected the thrombus, done a PTFE reconstruction and a thrombectomy of the embolectomy of the upper limb. And other services that we provide, other than vascular surgery and transplant service, we also do liver resections. This is a cirrhotic liver, left lobe HCC being resected. We are equipped with the CUSA and the machines needed for liver resections. This is a right hepatectomy done on a tumor which is encasing going under the IVC. And we do all sorts of segmentectomies and tumorectomies, and we help the GI surgeons to remove the secondaries. I also offer this service of massive splenectomies for the hematology colleagues. When they have hypersplenism, they can't control it with medication, they're referred to us. We have done 36 over the past couple of years, and we have got this technique right with the large varices and large veins which are thin-walled. We haven't had any mortality or major morbidity. And we could only collect, this is not all the data that has operations done in other theaters are not there. This is in one theater. The last 9 cases, they collected our research assistant. So this is tumors in the right kidney going into the IVC, sometimes to the heart. A few cases we have opened the right atrium also, and most of the time we can clear the tumor of the IVC after removing the tumor from intra-abdominal incision. The few cases. This is the last patient that 2 weeks ago I saw in the clinic, and I just put it. And we also do a few cases of like sarcomas, which when they are in between the aorta and the IVC. Thank you. And sometimes recurrence of sarcomas also we do, and a few adrenal tumors, soft tissue sarcomas. When the sarcomas are encasing or in close proximity to the vessels, we excise them and sometimes reconstruct them with a reverse saphenous graft. And we also do laparoscopic nephrectomies for non-functioning kidneys and help urology colleagues with minimal incision. And with the umbilical port, we generally pull the hydronephrotic kidneys out, and sometimes with the incision. Some interesting cases done over the years: a celiac artery aneurysm in an old man, a subclavian aneurysm. This is a young man with an infected pseudoaneurysm, which we opened the chest with a sternotomy, ligated the subclavian artery at the origin, removed the infected pseudoaneurysmal sac, and reconstructed with a reverse saphenous graft from carotid to axillary artery. And this was presented in the charting process by Dr. Vinojan, who was the senior registrar at that time. Carotid artery aneurysms. This is a splenic artery aneurysm, multiple aneurysm with a hypersplenism, remove the spleen and the multiple aneurysms. And this is a twin separation. One was a parasitic twin. This was led by Dr. Kasturi, our pediatric surgeon. Took 10 hours. My job was to separate the liver and the dual blood supply, the aorta and the IVC, and reconstruct the limb vessels. And this is the patient a little girl that we did many years ago. She met with accident, completely severed foot. We have reimplanted with, but it was a few inches short. So when it was insensate, so there was a lot of criticism when I did this. But anyway, the orthopedic surgeons lengthened the limb, and she is in the management faculty after obtaining 3 A's for her advanced level, and she's walking now, thankfully. And she keeps in touch and tells us all the achievements that she does from that time till today. Some responsibilities beyond clinical work. We also take on medical students. So the whole group of the whole batch goes through us for 2 weeks, and we take them very seriously and try to teach them some vascular surgery. We take elective students. I take registrars for 2 months appointments, and 2 registrars at a time generally, and senior registrars who are future vascular surgeons. Honestly, they are the pride of our unit, and 23 of them have gone through our unit, and these guys are performing really well in different parts of the country, and I'm so proud of them. And some of the last few are waiting to go abroad. 1 or 2 have left the country as well, but all of them are doing good work wherever they are. And our unit work has been published in national and international journals and different forums. And we also have some online platforms also with videos so that our medical students, registrars benefit. So that's about it. And I have special thanks and gratitude firstly to my parents. If not for them, I won't be here, and for all the love and guidance. My school, Royal College, Colombo, and Faculty of Medicine, Colombo, and postgraduate of medicine, all the teachers that have taught me over the years. And Professor Mandika Vijayaratna, who is not only my teacher, he's my mentor, he's my trainer, and he's my inspiration, and the reason why I'm doing vascular surgery. Because when I was his registrar, and I never thought I would do vascular surgery because couldn't sleep at all. So, but he invited me to do vascular surgery, and here I am doing vascular surgery. So thank you, sir, for all the help and guidance over the years. And special thanks to Dr. Selton Berra, who was the director at that time, who helped me to set up the unit. Dr. Ranga, who is the current director, who's really helping us to set up. I'm sure he will give us a CM as well, so that we have a hybrid theatre doing every whole range. And Dr. Lakmali, who is the deputy director, also so helpful. And none of these things are possible without an energetic, enthusiastic anesthetic team. Thank you, Dr. Keshari, Dr. Gajavira, Dr. Salia, Dr. Janak, and the rest of the team. And my nephrology colleagues who are present here, Dr. Iresha and Dr. Rangavira Kodi. All the transplants are referred by them, and thank you so much. And life is boring without good friends. So my colleagues have been there with me throughout our careers, Wesley, Nalak, and Charit. Our vascular team, it's all a vascular, it's a teamwork. So all the medical officers, registrars, senior registrars, nurses, minor staff, all of them have contributed to all what I presented. And the extended vascular family, the giants, and the rest of the team. And my colleagues back at home, back in Gaul, we do a lot of teamwork, and everybody is just one call away when you want an opinion or a referral. And I would like to thank, I'm so proud to call him my trainee. He was there in Gaul for Tushan Gururatna. Now he's a great surgeon, great scientist. He helped me with the oration, with all the analysis. Tushan gave a big hand. Thank you very much. And I'd really thank Dr. Sinesha, who's my research assistant, who worked for months going through details and collecting this data, going through old books in record rooms, and really putting this together for me to present. Thank you very much. Last but not least, my beautiful wife, Ilusha, for all the love and respect that she has shown me over the years, and she's actually the strength. She has encouraged me and excused me from family stuff and taken care of my kids. And my lovely and loving kids, Vishni, Adish, and Lakisha, who are here today, and thank you very much for all the love. If I have learned something over the years through this journey, and especially for young registrars and young surgeons who have come back or planning to do surgery, I just have to say that, have a dream, have a plan, and just work really hard. And invariably you will have lots of failures on the way and a lot of hiccups, and we will really fail the day that you give up. So if you don't give up and you work really hard and follow your dream, and the dreams will come true. And also on the way there will be people who try to put you down, few haters who will try to slow you down. Be encouraged by them. And in vascular surgery, sleepless nights, too much work, too many responsibilities, learn to be calm. And don't lose your kindness or compassion. Be kind to your patients. Be nice to your colleagues. It's not worth fighting with your colleagues for anything. And also look after yourself and your loved ones and your family. Thank you very much.